Let's go on to the next segment, which is starting to use the data. So now what we're going to shift from is sort of the philosophical into the insanely practical, which is what do the data look like and what can I do with specific variables? These, I just want to say as a caveat, these are large files and we are not going to cover every single possible variable, but we're actually just going to talk about some key ones that we think are particularly important or that offer opportunities or that in some cases are just a source of confusion. And just as before, we've got time for questions at the end of the segment. We've got Steph and Abby and Sammy monitoring chat. So a Medicare enrollment file is a file that contains records for all people who are eligible to receive the services over a stated period. Typically for these are annual files, so we will get a file each year. We will get an annual 2023 file, annual 2022 file, annual 2021 file. So just they're not a cumulative file, they're just annual files. And if you wanted to, you could rearrange into a cumulative file, but you don't have to. The files allow for calculations of rates, percentages, because you have for every person a record and the details about deciding what you want. They provide a common source of information for beneficiaries who do and do not have an outcome of interest. And this is sometimes the mistake that people make. It's relatively easy, which is we focus an awful lot on our numerator, on who has the outcome, and we forget to spend equal attention to who is eligible to get it and the people who do not experience it. So if you want to follow a cohort over time, and I say more than 30 days, because the honest truth is that people can die, people can lose their coverage. And so if you really, and these things happen regularly, so understanding and making sure that the people you are tracking and the inference you're drawing from whether or not you see things is correct. So as an example, understanding a lack of healthcare use. One of the areas that I spend a bit of time on is guideline compliant care. So what predicts who gets care in a guideline compliant fashion? And if I say, well, I don't see guideline compliant care, therefore they didn't get it, that's one thing. But if it turns out the reason they didn't get the care is because they forgot to pay their premiums and they were kicked out of Medicare, they disenrolled, then I would say it's a guideline problem. And in fact, it's an insurance problem. So it's really important when you're looking at times, periods of times and what happened, that you understand periods of time and that you rule out the really easy inference, which is they're not eligible to show up. As the other thing would be if we track beneficiaries across Part A covered services to Part B covered services. So as we said, Part A is an entitlement. Part B is an optional insurance. Most people have it, but not everybody. And so if we take hospitalized people and we say, I want to know how long it was before they had their first follow-up visit, or how many of them had outpatient physical therapy, we actually want to make sure that everybody who's in our hospital file is eligible to have their physical therapy covered by the Medicare program, which would mean having Part B coverage. In particular, the end-stage renal disease and the disability programs require us to track them because you can lose disability status. As hard as it is to get it, you can also lose it. With end-stage renal disease, kidney transplants result in people losing their status. That's actually good news for them, but what it does mean is that if for certain outcomes, we really can't see them. People can also lose their disability status. So it's not seen as a lifetime status. It could be that they were declared disabled and then at some point under a later evaluation that was changed. And then the other reason that you want to do it is if we're combining data from an outside source with CMS. I have a friend who only kept the people who were hospitalized for a VA linkage and forgot to keep the people who weren't hospitalized. And then realized because they couldn't do it, they couldn't differentiate between what weren't hospitalized and didn't link. They didn't get the enrollment data. So the Master Beneficiary Summary File is the current name for the Medicare enrollment file. So the Medicare enrollment file, like a lot of stuff with Medicare, has been renamed from time to time. The biggest risk for you all, just so you know, is one that I will slip up and use old terminology. And so you'll be like, what is she talking about denominator? And it's just, I'm using old terms. But it also might mean that when you're reading an older literature, they'll be referred to a different file. Like I'm using the MBSF, I'm not using a different file. And so just knowing the file has been renamed, it's been expanded, but in fact, the basic contents have been unchanged since the early 90s. So the current name, Medicare Benny Summary File, it has one line for each person enrolled in the Medicare program at any point during the calendar year. For one day only, they will show up. It contains the detail of enrollment. It contains demographic information, and it contains some, or it can contain some summary information from claims. The Medicare Benny Summary File right now has 5 segments. It has the base file, sometimes called the ABCD file, and that contains eligibility and coverage with Part A, Part B, Part C, and Part D, as we said, which is what the name is. It's available right now from 1999 to 2022. I do want to point out to you an important thing. When CMS updates a data field, they don't always, and they often don't backfill the data. So the variable name will be there. It will just not contain anything. And that's certainly a mistake that I've made at various times. Like, oh, look at this. It goes back. It says it as Part D back to 1999. Well, we know that can't be correct because Part D didn't exist in 1999. But going back to 99, there will be Part D eligibility variables. They just will be blank. So do take time, if there's a particular variable that you're really excited about, to read the documentation, to check with ResDAC, to ask around to find out when that variable was first populated. There also is a segment called chronic conditions, and these are segments that we'll talk about on Thursday, first segment on Thursday, and these are based on algorithms from the claims. They can be useful, but they are also algorithms that are applied, so they may or may not exactly suit your needs. So definitely, and Nathan will talk, hopefully he'll be feeling better, we'll talk about it, but do consider those. And then there's another field called other chronic conditions, because there were so many more conditions that had a claims calculatable phenotype, that rather than making segment 2 really huge, we added a third segment. There's a field called cost and utilization, which contains summary information about use. And these are all 3 segments, 2, 3, and 4, are all from the fee-for-service data, or the original Medicare data only. So if somebody is in Medicare Advantage, their information will not be in these 3 files, or 3 segments. And finally, the National Death Index death information. And that is important. We'll talk about the VRDC on Thursday. You only can use the NDI data in the VRDC, but even then you need to have, as I said earlier, a scientific case for needing the cause of death information. It's available. It's a massive benefit to us, but there are restrictions given the nature of it and the rules surrounding use of NDI. So understanding the file itself, what the file does, there are a variety of sources of data that CMS draws from: Social Security Administration, Managed Care Organization, the Railroad Retirement Board, which is sort of a increasingly less important sort of parallel retirement system to Social Security, from states, and from claims themselves. And all of those things contribute to CMS's internal data set. That internal data set, which is massive, is currently called the Common Medicare Environment. That data set has also been renamed a few times. And from that Common Medicare Environment, there are a couple of things that happen. In some cases, the information triggers an investigation. So the data themselves don't actually come in, but they trigger something which then can lead to something else. In some cases, there'll be a direct flow. But from that, on an annual basis, the Master Benny Summary File is created. So it's not just Medicare data, but it's also information from other sources that all come together to help everybody get a snapshot of the status of that beneficiary. The Common Medicare Environment is, again, taking data from other variety of sources. It contains eligibility, enrollment information, and officially they say every beneficiary ever entitled to Medicare. I don't know if that is true. We are not allowed to use it. It exists and it is the basis for pulling, but this is not something that any researcher ever can get access to, and it is not worth even asking about. But once a year, that is the big data system that CMS uses that is the basis for the CMS denominator file and the Master Beneficiary Summary File. There are some considerations as you're thinking about this. There are times that things change over time. And one of the shifts that I definitely have seen in CMS is their policy around things. So it used to be we got one measure once a year and we had to live with it. Now there are many more variables where we will get the variable or part of the variable measured at multiple points in time every month. That's sort of an advantage, and in some cases can be a problem. But let's just start with the simple one, which is age. Age can either be we will get actual date of birth, and age can be the day they are in the beginning of the year, so their date on January 1st, their date on December 31st at the end of the year, or it can be something more complex like the date that they were last eligible, which would either be date of death or the date at the end of the calendar year if they were still alive. So understanding how old somebody is sometimes not a trivial thing. In many cases, what I find I want to know how old they were when they were hospitalized, in which case I will use date of birth and I will use admission date and calculate it myself. So again, using the summary variables, you have to ask, how precise is it and how much am I bothered by any imprecision there is? The most common options are the value on January 1st, the last value previously CMS would often do the value that was noted when the file was created. That is less of an issue now than it was, say, 10 years ago. So who's included in the Master Beneficiary Summary File? As we said, and this is really important, annual, all beneficiaries enrolled for even one day. The file isn't limited to new enrollees, and in fact, you have to create your own algorithm to find them. There's no specific indicator for new beneficiaries. Eligibility for Medicare is determined by Social Security and the Railroad Retirement Board. It's not determined by Medicare. And when you're asking for the data, you will get all benefit groups unless you specify otherwise. So if you say, no, I really only want the elderly, if you don't ask, you will get everybody. It will get caught sometimes, and I don't mean that in like a negative way, but people will help you. They may say, wait, I'm reading your aims, and your aims are talking about care for people with end-stage renal disease. Do you really want people without end-stage renal disease, or did we just forget to put that limitation on? So again, with people will try to help you because it's balance minimum data necessary and to make sure you actually get the population that you seek when you're doing this. Medicare has some unique identifiers. Medicare itself, in that big database that we're not allowed to see, uses what's called the health insurance claim number. And the health insurance claim number is composed of two parts. It is a 9-digit CAN or claim account number, which is almost always a Social Security number under which benefits are claimed. So what that means is, if I'm getting Medicare benefits based on my own work history, it will be my Social Security number. But if I'm getting Medicare based on my husband's work history, then it would be his Social Security number. So that's the CAN. And then the 2-digit BIC, or beneficiary identification code, says how I relate to my justification for benefits. So that what that would mean is that if they're mine, it would be my Social Security number plus an A and a blank, which says this is her Social Security number, but if it was a BIC, it would say she is claiming benefits as a spouse. So that's how we do it. That number has been around forever, but the problem we have is that it's got a Social Security number, and this was the number that used to be on Medicare cards. Beginning in 2018, they created a new system, a new intelligence-free system called the Medicare Beneficiary Identifier, or the MBI. The MBI is not delivered to researchers, and it's only used in cards. And what it does is it's a random number and it reduces risk with security breaches. So what happens is people lose their purse and it's got their Medicare card in it. They may lose their MBI, but they won't lose their Social Security number. It means that if there's a breach with healthcare providers, they don't lose Social Security numbers unless they're otherwise collected. So this was made for beneficiaries to provide some level of security for them because there were so many issues of lost Medicare cards and that being a source of people getting Social Security numbers. What we use and what we get is what's called a Beni ID. And the Beni ID is a unique identifier for each study. So for each study, they will uniquely encrypt the study with what's called a beneficiary ID. So if I have a study with 10,000 records, I will get beneficiary IDs. If Steph has a different study that has 20,000 records, she will get a different list of Beni IDs. And even if we think our data are overlapping, if we merge them, we would not find the same people unless we say to them, I want to update my study with Stephanie's study, and therefore we need to be able to have a common linkage between the two. So what it is the Beni ID is for research. It doesn't matter if somebody loses their Medicare card. It doesn't matter whether they claim benefits on their own work history or something else's. It takes all of that out. We don't have to deal with any of that. So what it is now is we've got the ID that CMS uses, the ID that is put on the Medicare cards, and then a study-specific ID. So they're all different with the goal, again, of protecting our beneficiaries and limiting the risk that they are somehow or other subject to security breaches. So if we want to identify patients across file, we use the Beni ID. But that also means we need to be, when we get data and we look at studies, we have to be transparent with CMS. If I have a plan of combining my data with somebody else's, I need to tell them that we can use a common encryption, a common Beni ID. If we don't do it, it's not possible. But if I get Part D data, the Master Beneficiary Summary File, the institutional files, so inpatient and carrier, the Beni ID for all of those will be common. That means that I can tell across all these files, the same person, put that person's history together. We can also use it and create crosswalk files if we're going to link it with external data. So this is really good. It's certainly made it easier. I had many times over the years where I would be arguing with the IRB. We used to get Social Security numbers, and the IRB said, we don't want you to have Social Security numbers. And it was really hard because that was the only way CMS gave it. So then I was trying to balance between CMS sending them to me and my IRB not wanting me to have them. So the Beni ID solved all of those problems because it is also an intelligence-free identifier. If somebody were to get a list of Beni IDs and nothing else, by no means optimal, but they have no meaning. So just do understand that, and that it's rather than complaining, this is something we should be thanking CMS for. So when we look at the MBSF, the base segment has demographic information. There's age, date of birth, sex, race, place of residence, and date of death. Sex is coded as 1 male, 2 female, 0 unknown. There are very few unknowns. Every time I read that, it always gets me a little nervous. But in fact, out of 60 million beneficiaries, there are fewer than 11 who have their sex coded as 0. So the question is, well, how accurate is it? So one of the questions, because we've heard you may get some minor mismatches, but as we said, most diagnoses aren't gender related. But when I compare, for example, gender and gender-related diagnoses, prostate cancer or endometrial cancer, what we see is like around 0.02% mismatch where the combination doesn't make sense. So you may see people saying, I found women with prostate cancer, and the answer is right, but it's like less than, it's 0.2%. It's a very small percentage. But of course, if you multiply that by 25 million, which is the fee-for-service population, it gets to be a big number. So just be aware that there's always, in any data set, a very, very small amount of noise. But from my conclusion, and for me, I just know it. And if I see these things and if they matter, I can decide what to do with them. There will be minor things, but it's in fact, the data I think are pretty impressive. Age is calculated at the end of the year if alive or at the date of, or the age of date of death. So if you check it, you've got to remember to handle the people who died. Otherwise, you will conclude that there's about 10% errors. Some people, there still are stray people in the file, not as many as there used to be, where we don't, it looks like they're being carried along. So when we look at the Medicare data for Medicare 2020 data and this 2020 census, those two numbers are almost the same. Census estimates a few more. And if we look at people 95 to 99, we see very similarly good numbers. But when we look at people who are over 100, we see Medicare seems to have significantly more people than the census does. And we'll go through it, but I think I just want to know that this does exist. And when we look at it, what we see is that there's a disproportionate number of people who don't have who are listed as over 100 who don't have Part B coverage. So they're not paying the premiums and who don't have any healthcare use. So from this, my conclusion, and you are certainly free to reach a different one, is that these are probably deaths that were missed at some point, probably 20, 30 years ago. And because this is an insurance company and nobody wants to cut off insurance for people who are, 104 years old and frail, they are kept in until they can find evidence to remove them. So it's a smaller problem than it used to be. There are a few. The way we do it in our studies almost always is we restrict on having to have Part B coverage, and that takes care of most of it. And if we're still worried, we can say, and this is what I mean by face validity, do I think it is possible for somebody who is over 100 to never encounter the healthcare system during a year? And usually with those cases, we say, no, that really doesn't sound right. They're either getting care somewhere else, in which case they're incomplete, or they probably aren't still alive. But it's a small problem, particularly given the percentage of people who are over 100, but do know it exists. And like a lot of stuff, we just have to make the right decision for our particular study. So there's no standard way of removing them. As I said, what I usually do is require people to have Part B coverage anyways. We can get sort of snarky and say anyone older than the oldest person in the US. In general, these do not look like these are digit related, like somebody was born in 2004 and it was listed as 1904. I don't think it's those. I think it was just people where deaths were missed or not reported properly. And again, as the insurance company, CMS will not remove somebody unless they know for sure they can. Now, date of death that information comes from either the Social Security Administration or the Railroad Retirement Board, depending on the two systems. Claims can be used to trigger a process. So if a hospital reports that somebody was discharged dead, that will trigger a Social Security Administration process to investigate whether that person has died. Nobody from a hospital error will ever have their Medicare benefits lost. So it just triggers a process by Social Security. In the data themselves, the dates are missing if the beneficiary is alive, they're non-missing if the beneficiary is deceased. So if the beneficiary is deceased, it's the date of death. And again, you don't need to worry that it's based on a hospital discharge. But I will say, when I compare hospital discharge data with discharge status dead to date of death, the alignment is near perfect. Sometimes they're off by a day, and that's probably the died close to midnight minor errors in hospital data. If you look at older versions of this course, we would talk about death validation. And what was happening until somewhat recently is there were two fields. There was date of death and death validation. So what happened was that 100% of the deaths were validated, but not 100%. The decimal place is in the wrong place there. I apologize, but 100% of death dates were validated, and non-validated death dates were assigned a date at the end of the month. Again, from an insurance perspective, we don't want to cut off services while somebody is still alive. What you can see is that after some looking at it from our side, we found it was the Railroad Retirement Board, which is an alternate retirement system in the US. It was Railroad Retirement Board's ability to communicate with Social Security that resulted in this. That problem was fixed in 2013, and we probably could get rid of this slide, except for the fact that for some of you who have heard this or have seen this in older publications, I've been reluctant to get rid of it. But also, it's a beautiful example of when something starts changing over time, even if it's not something you care about, it's something that you might want to take care of and figure an answer out. So race was previously coded before 1994, so before the Stone Age, as white, black, other, and unknown. Effective in 1994, race codes were expanded to white, black, Asian, Hispanic, Native American, other, and unknown. The answer for why it is done this way is something that seems crazy to anybody who's learned modern computer science. But at the time this was done, in order to have a separate race and a separate ethnicity field, they needed to add one more column to the database, and they didn't know how to do that, which again shows how far computer science has changed from 1994 to present. So it's out of compliance with OMB, which requires separation of Hispanic ethnicity from race. Unfortunately, because of the way it is coded, to actually do this would involve contacting just about everybody and asking them to self-identify. And we certainly have seen other examples where we say, hi, this is the government. What is your race? What is your ethnicity? Those aren't always well received. I do want to point out that although things can change, we actually did a study where we looked over a 9-year period to ask how consistently is the racial identification with all of its errors. And we found it to be 99% consistent over a 9-year period. So what that means is it may not be perfect. It may drive us a little crazy, but it isn't changing dramatically year to year. So if that provides some assurances, that's at least where we can be. Just so you know, for example, the Hispanic code has an estimated sensitivity of about 35%. So the Hispanic code, while we're not questioning people who are identified as Hispanic, it certainly is not complete. Based on some work that was started at the University of Miami in the mid-90s, CMS hired a contractor called RTI to implement algorithms that were created at UM to create a race code. They use names and other information. And so when we look at Puerto Rico as an example, if we look at the blue, we see that using CMS race code, Puerto Rico is 22% Hispanic and has been consistently between 16 and 22% Hispanic for forever. But in fact, with the RTI race code, we find that it's almost 100% Hispanic, which is consistent with the census and other information. So we use Puerto Rico as an extreme example, but also if we think about other populations, with other areas with large Hispanic populations, we again find strong face validity. So this is also an example where we do not know the truth, but we do know we can look at this and say, does this match what we think it should be? As I said a few minutes ago, race is consistently classified over time. So both for Medicare race and RTI race, they did not change from the period 2010 to 2019. And we found the concordance for both females and males. So even though they may use, in some cases, they may use surname matches, we did not find any issues or any concerns that somehow the concordance or consistency was changing. Residency is an important thing. We want to classify people. We want to find out how close they are to healthcare systems and so on. There are annual variables, state, county, zip code of residence. These are the mailing residence for official correspondence. Analyses and consistently over time, comparing state of treatment with state of residency generally show high concordance. Not perfect, obviously, but high. The denominator, the MBSF, is based on information from when the file is finalized. The beneficiary summary file reflects residence based on as of the end of the calendar year. I point out something here, which is SSA format. So they're actually in our federal government, there are two ways of classifying geography. There's the SSA, the Social Security Administration, and there's FIPS, Federal Information Processing System. They alphabetize differently. It has to do with where they put Guam and a couple of other things. It also affects how they classify counties. So one of the things that happens is, well, we have monthly variables and annual variables. If you compare the annual variables to the monthly variables, you will find, starting in about Georgia, that they do not agree. And the reason they do not agree is because they're coded using different coding systems. So if you want to match with census, you actually want to use the FIPS format. You do not want to use the SSA format. So this is some of the craziness of these data, is that, but it's also an example where if you're seeing patterns that don't make sense to you, why is everybody from Indiana receiving care in Kentucky? That may not be quite the right adjacency. You can call us. We will help you do this, because again, these are the kind of questions that make no sense. Why don't these things line up? They ought to be perfect. And the reason has to do with coding systems, and it is in the data dictionaries. You can see it, but it also is buried a little bit. And if it didn't occur to you to look for two federal coding systems, which I think for most of us it wouldn't, you could find yourself very confused, as I did a few years ago. Entitlement information. So as you've been hearing, there's original entitlement. Now, original entitlement is the classification. So you'll notice one of the things that I think is sort of curious is we sometimes say it's old age. We sometimes say it's elderly. We sort of aren't even consistent in the Medicare program and what we call these people. But the original entitlement says when somebody started in the Medicare program, why did they get it? So original entitlement is the first day you were Medicare eligible. Was it because you were of age? Was it because of disability? Was it because of end-stage renal disease? Or was it because disability plus end-stage renal disease? So you can have both of the two. Current entitlement is the same. So if somebody original entitlement was disability and they've now aged into Medicare, their original entitlement would be disability. Current entitlement would be old age. So that's one way when we want to look at what happens to certain people or people with certain diagnoses as they age in. That is one way we find them. Or when we were doing work looking at what's called pent-up demand. So this would be worrying about people who might not have had health care until they turned 65. Did they hold off on certain things, and what happened? We wanted to remove the disabled population from that, because the disabled population were already in the Medicare program. So those are examples of studies we wanted to do where we might make decisions to include or exclude people or use them as a comparison group. I want to point out ALS there is no ALS indicator. So if you want to study ALS, under age 65, they're disabled, greater than or equal to 65, they're old age. So what you need to do to find people with ALS is you're going to need the claims, and you're going to need to create a claims-based algorithm to find them. So this is, again, where you could see the MBSF can take you part of the way, but may not be able to take you as far as you want to go. Current reason for entitlement, again, consistent with age, 86% elderly, 13.7% disabled, 0.2% end-stage renal disease only. So the disabled green ring includes disabled with end-stage renal disease and disabled without end-stage renal disease. The Medicare status code is a different way of doing things, and it's a monthly code, and it covers on a monthly basis whether somebody wasn't enrolled was aged without end-stage renal disease, with end-stage renal disease, disabled with or without, and end-stage renal disease only. So I want to point out that one of the values of one of the important pieces of this code is actually the not enrolled, the 0 zeros. This is the field you use if you want to find out on a monthly basis whether somebody is in Medicare. So if somebody ages into Medicare in May, let's say, then in January, February, March, and April, their Medicare status code would be 00, not enrolled. If somebody died in November, in December, their Medicare status code would be 00, not enrolled. So that becomes a really important variable if you want to get down to person months at risk, if you will, to find out how long somebody was in the program. So again, using the aged Medicare status code 10 and 11 works really well. But in fact, the biggest reason that we tend to use this field is actually for the 00 zeros, for the not enrolled, and to know that on a monthly basis. I want to point out that the beneficiaries in the 3 programs are importantly different. And it's important because sometimes when you'll read papers, you'll see numbers that don't make sense. Say mean age of 67 years, or you'll see things. And so I want to point out that the programs are different, and depending on what you're trying to do, it may not make sense to combine them all into a single lump. So with the elderly, as we've talked about before, there's a predominance of women, 55% female. The annual mortality for the elderly is about 4%. The mean age of our older population is 75 years. And interestingly, the top DRG for inpatient care is septicemia, so an infection. For the disabled, it's again almost 50-50 males and females. The annual mortality is 2%. And that makes sense if you think about the fact that there's a 2-year waiting period before their Medicare benefits kick in. What it means is we have a disabled but relatively healthy population. So the lower mortality shouldn't be surprising. Their mean age is 53 years. Again, it makes sense that their mean age would be considerably younger than 65. And the top DRG for inpatient care is psychoses. For end-stage renal disease only, this is actually a male-dominated diagnosis, percent male, 58 years, annual mortality much higher, 7.6%, mean age 52 years, and the top DRG is disorders of nutrition, metabolism, fluid, and electrolytes. In other words, complications from end-stage renal disease. So notice the point of all of this is that if you look at them in terms of gender, age, or mortality, or even healthcare, they're quite different. You will still see some people say, I studied the Medicare population, the average age was. And I just encourage you to take a moment, if your population includes all 3 programs, to really stop and think whether or not you want to pool them all, how you want to pool them, do you want to stratify, and so on. So enrollment information. Now, we spent the morning talking about Part A, Part B, Part C, and Part D. And in fact, this is the file, the ABCD file, as we call it, where you'll get that information. Most beneficiaries will have Part A and Part B. About 91% have both A and B at some point during the year. Those who have more of one tends to be more A than B. And we sometimes see this with new enrollees. It's like the A kicks in before the B does. It's not enough to result in a penalty. I think it just has to do with administratively when things hit the system. So I will admit that although I tell you my algorithms say you must have equal months of A and B, there's a little asterisks there, and they say except for in their first month of enrollment, in which case we can allow them to be A only. But I rarely see it for more than a month. Beneficiaries, as we said, are not required to have Part B. Part B is optional. And about 8.5% of beneficiaries have only Part A at some point during the year. Often these will be younger elders, if you will. And probably what it is either they are still working, so they have private insurance, or perhaps they've got a spouse who is still working and they're getting insurance from that person. So rather than paying the Part B premiums, they're able to opt out by showing that they have similar coverage. As I said earlier, and I'll say again, and it's important, Part B benefits can be waived and restarted without penalty if you show that they have other health insurance that provides the same coverage. That is the good news. The not so good news is right now there is no indicator that allows you to measure that. Medicare benefits are determined on a monthly basis. CMS gathers and maintains the information, including Part A, B, C enrollment and disenrollment. The question sometimes is, do we consider A and B differently than A only? And what does it tell us? And the concern is, well, if I want to study a Part A benefit, why do I care about B? And the reason, the reason for me at least is I worry that there's a reason people have A only versus A plus B. There's a reason that they choose not to have comprehensive health care, and that reason may bump into my ability to measure the thing I care about. So what this shows is Part A utilization by age and by whether or not they are A plus B versus A only. And what you can see is that at every age group, the hospitalization rate goes up, first of all. So 65 to 74-year-olds, 75 to 84, and 85 plus. We can see that rate go up, but we can see the rate goes up more for Part A plus B than A only. And at no point are the two rates similar. So to me, what that tells me, again, is that people who are A only, even when looking at Part A services, are different than people who are A plus B. So if I'm worried about accurately measuring hospitalizations, and I'm not worried about getting all the other claims or all the other stuff, I still worry. And I worry that I'm missing hospitalizations if I allow A only into my cohort. This is my worry and my thing and my craziness. You can choose a different approach. You can decide you're okay with it. I'm not questioning the validity of those hospitalizations. I'm questioning the completeness. So this is, again, one more way these data are tough and exciting. They're tough because there are decisions to be made that we don't always even want to have to stop and think about. You want to say, just get me the tables. My abstract is due in 3 weeks. As I said, these are not data for the impatient. We talked this morning about dual enrollment. Every state has an option of paying Medicare premiums for at least some people. There are 3 different programs that states can do to help people out. And they used to have a whole SLIMB, QIMBYs, QIs, but again, broadly, for about 14% of people who get state help. So 20% of people have state help. For 14% of them, the state helps them pay their Part B premiums or their Part A premiums, depending. For another 14%, they pay premiums plus cost sharing. They pay the copays and the deductibles. And for 72%, the state provides full Medicaid benefits. So the reason the states go this route is because it is cheaper for the state to say, we'll help you get your Medicare, and then we'll pay for the additional services you need. That costs the state less than saying, we're going to opt out of Medicare and have Medicaid cover everything. This is noted in the MBSF file as state buy-in. So what it tells you is that the state helps in some way, but it actually doesn't tell you how they help. So what you know from the state buy-in is they get help with at least premiums and possibly up to full Medicaid benefits. The source of the data is from the states. And what happens is when the premiums are paid by the state informs CMS and then the CMS bills the state instead of the beneficiary. So the idea is that this is a way the state says, here's the roster of people we're covering. CMS no longer bills the beneficiary, but sends it straight to the state until the state says stop it. So this is a way to make sure that these people don't lose their benefits, and it's driven by state reaching out. There's also buy-in information on a monthly basis. For each month, there's an indicator, not entitled, Part A entitled, Part B entitled, Part A plus B entitled, Part A state buy-in, Part B state buy-in, Parts A plus B state buy-in. This is an indicator of what is to be billed to the states. Okay, this is about premiums. So the reason you'd have a Part A state buy-in would be because they do not work their 40 quarters and they need to pay to get up to full eligibility. Part B could be covering the premiums, and Part A and Part B means premiums plus copays and cost shares. Notice the zeros, not entitled. The reason you would be a zero is because you are not in the Medicare program. So this is, again, an important way of finding people who either aren't yet eligible or who have died or who have lost their eligibility. Many people say we've adjusted for poverty. And this is one of those pet peeves. I will warn you, if I get asked to review an article and you say we adjusted for poverty and then you put in parentheses state buy-in, I am one of those reviewers that will comment on it. And the reason is only 66% of the beneficiaries who report an income below the federal poverty level have state buy-in. So there are plenty of poor people who don't have state buy-in. Getting state buy-in requires having low income, poverty, and making it through a process. So there are plenty of people whose incomes would qualify, but they do not make it through the process of getting this extra assistance. So this is the piece to understand and to make sure, again, that you're clear on what the inference is and is not. Beginning in 2006, you can actually figure out different codes. There's QIMBY, QIMBY plus Medicaid, SLIMBY, and these are all various descriptions that aren't obvious. And I've got to admit, I sort of skim over this because a lot of the descriptions of what it includes aren't clear to me and aren't always obvious. So what you need to do is think about functionally, what are you trying to identify? You're trying to identify people who get help with their premiums. You're trying to get help identifying people whose incomes are lower. Think about sort of very concretely, I am using this variable in order to do what? And then you'll be able to use these definitions to figure out how they all come together. So, polling question. So the answer, about 2/3, about 3/4 of you got it. Medicare pays before Medicaid. So this is the reason why it is easier for the states to help somebody get into Medicare. So if we think about hospitalizations where there is a $1,400 deductible, Medicare pays all but $1,400, and Medicaid would be left with the deductible or the $1,400. So this is an example where the order of payment, again, private insurance pays first, Medicare pays second, Medigap, which is like a private secondary insurance, pays third, Medicaid pays fourth. Whatever is left after all of that as eligible would go to the beneficiary. Part C, managed care enrollees. So I apologize. It's managed care enrollees are required to have both Part A and Part B benefits. So that's first of all. So when you think about an ABCD file, we would see them to have A plus B, but then we'd also see them in managed care. Managed care organizations transmit the enrollment, disenrollment information, as well as enrollment corrections to CMS. So again, CMS doesn't assign people. The plans say, here are the people who are enrolled. The accuracy of these data ensures that they're paid a monthly premium from CMS, but also they use it to make sure that claims that are inadvertently submitted to CMS are rejected. So if somebody is in managed care and then a hospital submits the claim, CMS would reject it, saying they have other insurance. In some cases where there have been problems with people mistakenly enrolling in managed care or not understanding, that is exactly when they find out, when they get hospitalized and it gets rejected all around. CMS is actually, in my personal understanding, and for some personal cases, is actually very gracious to elders who may have enrolled in managed care and not realize it. The monthly indicators, there are both monthly indicators in the file and a summary count of months of HMO coverage. Summary count doesn't distinguish across types. And beginning in 2006, there now is monthly information on contract numbers and benefit packages and plan types. So it used to be, so if you're looking at data over a period of time before 2016, you could tell that somebody was in managed care, but you couldn't tell which type, what they had, how much they were paying, what it covered. And which also meant you couldn't tell switching among plans. Beginning with 2016, you now know much more about the type of managed care and what benefits somebody is getting from managed care. So we now are at a point, if you think about where we've got the encounter data, which actually shows what people are experiencing, combined with this enrollment information from the Medicare, from the summary file, we now can actually start understanding how managed care is being used and how people with Medicare are experiencing managed care. Risk HMOs are the basic way. Their plans are paid a monthly amount per member per month to cover the costs of all Medicare services under Parts A and Parts B, except hospice. Additional services such as pharmacy are provided as indicated by the contract. There also is this old thing, and they've now been phased out, but you'll see them if you're using older data, which are called cost managed care. And cost managed care plans were this idea that CMS and the plans could share the efficiency. So it was based on a theory of how managed care worked and where the efficiency was. They were definitely market specific, and they were confusing. So I would just say the question is, with all of this, is what can I tell? So some with these cost managed care, some claims would show up in the fee for service file. I actually have never checked to see what shows up in the encounter data, but these would definitely be ones where if you really wanted to understand cost managed care, you would want to spend some time and spend some quality time reading regulations. And I guess my other advice there would be, I wouldn't go down that path unless I really wanted to understand managed care. I wouldn't just try to do it to get some marginal improvement in quality of data or something. So when we look at the monthly indicators, as an example, we've got not enrolled in managed care. Now, some of these people will be enrolled in Medicare, but not in managed care. And some of them won't even be enrolled in Medicare. So that's zero. That value of zero includes people who are not yet enrolled or who have died, as well as people who are enrolled but are in the fee-for-service system. The non-lock-in, that 500,000 to 265,000, that is the cost managed care. It is a very small experiment that is now completely gone. And the lock-in group health organization to process all claims, that is the risk managed care. So that is what these variables mean. So C is managed care. 0 is not managed care, but does not necessarily mean fee for service. And the ones, the non-lock-in, are the cost managed care that, again, I would encourage you to be very careful and thoughtful about whether you're going to go there or not. So for Part D, again, on a monthly basis, we can know enrollment, plan contract, benefit package, employers, drug subsidies. So that these would be people who say they don't need Part D, and market segment covered by the plan. Plan types, we've got choices here. And for Part D enrollment, I want to point out just about everybody who's in managed care has pharmacy as part of it. So 97% of managed care enrollees are ABD. They have Part A, Part B, and Part D. But only 58% of people in fee-for-service have Parts A, B, and D. Another 27% have Parts A and B, but not D, and 14% have A only. So you can see that the comparison of fee-for-service and managed care isn't just a matter of how their benefits are being managed, but is in fact can be something much more complex. So again, what it means simply is that we need to be very thoughtful in how we compare fee-for-service and managed care. And if we think about it in terms of a causal story or in terms of inference, we just want to think. There also are other files, other segments. There's the chronic conditions and other potentially disabling conditions. These are variables which indicate the presence of treatment for chronic conditions using claims-based algorithms. It is, we will get indicators for everybody, whether or not they have them, and there will be multiple flags. They may not be as precise as you want. Nate will be talking about this again on Thursday, but the advantages are they use a common documented approach in similar algorithms. Examples are diabetes, fractures, asthma, depression, bipolar disorder, epilepsy, depression. So they cover a huge range of chronic and acute conditions, but you do want to spend the time understanding how they're decided and decide again for you whether this is the right way to do it or not. There's a cost and use segment, patient level utilization. It's based on fee-for-service claims only. So if you're doing a study that mixes fee-for-service and managed care, this segment is not going to be helpful. It includes summaries, acute inpatient stays, ambulatory surgical center stays, dialysis, imaging, hospital outpatient emergency room, and such. And again, these can be very useful, but they're also very specific because of the way they're summarized and what they count and what they don't count. So do take the time to look at them, to think about them, and determine whether or not they're going to meet your need. The other way I want to point out is these algorithms, even if we don't love them, even if we think they're imperfect, I many times have used them to check my own data or to check that I'm not missing a code. So you can sort of say, they're not perfect. They're not perfect enough to use, but they're perfect enough to use for inspiration. So again, don't just dismiss these, but do try to be a little cautious. It does not include services to managed care enrollees, and variables will be missing if they didn't use a service. So it doesn't have a 0, it would have a missing. National Death Index. The data obtained by the CDC National Death Index includes date of death, cause of death. Files require additional approval from the NDI Advisory Board, and these data are not available in physical form. You need to be part of the Virtual Research Data Center. But they are a massive help, and there are many situations and many questions we can now answer that we couldn't previously. In 2016, about almost 99% of deaths in the MBSF also appeared in the NDI. So this is, again, agreement that is unheard of good. Less than 1% had a difference in death date between the two segments, between what Social Security said and what the death certificate did. And the median difference was 1 day. So again, some people have occasionally asked me, am I worried about linkage errors? I'm not worried about linkage errors. I think this is absolutely fantastic, and I am very grateful. I actually wrote a paper in the late 90s advocating for this, so I'm delighted that it happened. So, polling question. Steph? Okay, I don't know if you can see this or not. The question is, do you need to do anything extra to get cause of death information? 74% of you got it correct that yes, you need to do other things. You need to ask for permission and fill out additional paperwork that explains the scientific basis for why you need it. You also need to agree that you will get your data and do all analysis in the VRDC. So just to reinforce, it is available. We can be very grateful for it, but there are restrictions to its use. So now, key takeaways. The MBSF is always useful. You always want it. I can think of, and I've been part of ResDAC since 1998, and there are vanishingly few people who have convinced me for their particular study it isn't needed. It provides valid demographic information that is recorded using consistent rules. It has monthly enrollment information. It allows for easy way to define population, clear inclusion-exclusion criteria. It facilitates stratified and sensitivity analysis. We use it a lot for problem solving, logic checks, and so on. So even if we don't actually think it's going to be part of our publication, often some of those things, including trying to assess bias, would not be possible without this file. As a reminder, the Medicare status code 10 and 11 is a really good way to identify the elderly. Many times we want to limit our studies to something sort of like persons likely to have complete original Medicare claims. This is typically Part A and Part B coverage, equal amounts, but in the first year you can have one more month of Part A. No managed care enrollment. We often require that these are met for some period of time. For example, for hospitalizations, we often want a look back period. So we'll say from 1 year before an event to 1 year after, so I can get comorbidities and I can get outcomes. If you want to get Part D coverage too, again, it's somewhat not random, but you can put this in. We want to know what medications they were on before. We want to know what new medications and so on.